What if I told you that one of the most common health conditions affecting men worldwide is something almost nobody talks about? Over 322 million men will be affected by 2025. It strikes at 40, at 30, sometimes even in your 20s. And here's the kicker. It could be warning you about something far more dangerous happening inside your body right now. Today, we are diving deep into erectile dysfunction. What it is, why it happens, how to fix it, and what your doctor might not be telling you. Stay with me. This could change your life. So, what exactly is erectile dysfunction? In simple terms, it is the consistent or recurrent inability to achieve or maintain a penile erection firm enough for satisfactory sexual activity. Not just one bad night, not tiredness after a long day. We are talking about a persistent pattern, difficulty on at least 75% of sexual attempts, lasting a minimum of 6 months and causing real distress in your life or relationships. The medical community defines it precisely. The DSM-5, the gold standard psychiatric manual, requires that the problem occurs on almost all occasions, roughly 75% or more, persists for at least 6 months, causes clinically significant distress, and cannot be fully explained by substances, another medical condition, or purely a relationship problem. The ICD-11, used globally, defines it similarly as a marked reduction in the ability to attain or sustain an erection sufficient for satisfactory sexual activity. Now let's be clear about what erectile dysfunction is not. It is not a single episode of difficulty after too many drinks. It is not performance nervousness with a new partner. It is not priapism. That's the opposite problem. A painful erection lasting more than 4 hours that is actually a medical emergency. And it is not Peyronie's disease, which involves penile curvature from fibrous plaques, a structural issue, not a blood flow problem. At its core, a healthy erection is a blood flow event. Sexual stimulation triggers the nervous system, which releases nitric oxide, which relaxes smooth muscle in the penis, flooding it with blood, up to 40 times the normal amount, while outflow is restricted. ED is when this elegant process breaks down. The question is, why does it break down? And that answer is more complex and more important than most people realize. Ready for the numbers? Hold on, because these are staggering. In the landmark Massachusetts male aging study, conducted on over 1,700 men aged 40 to 70, a full 52% reported some degree of erectile dysfunction. That means more than half of all men in midlife are affected. Complete ED, meaning total inability, jumped from just 5% in men aged 40 to 49, all the way up to 15% in those aged 70 and older. Globally, approximately 322 million men will be affected by 2025, up from 152 million in 1995. That is more than doubling in 30 years, driven by aging populations, rising rates of diabetes, obesity, and cardiovascular disease. Now here is something many people do not expect. ED is not just an old man's problem. In men under 40, chronic ED affects roughly 1 to 10% depending on the study, but situational temporary ED due to performance anxiety is far more common. Some studies report figures as high as 22% of men under 40 experiencing ED episodes. A 2014 review found that 15 to 72% of men aged 18 to 39 with ED have an organic, meaning physical cause, including early vascular changes. Among men with specific health conditions, rates skyrocket. Diabetic men have an overall ED prevalence of approximately 52.5%. Men with type 2 diabetes specifically, a staggering 66%. That is an odds ratio of 3.6 times higher than non-diabetic men. Long COVID has emerged as a new player. Studies show ED reported in 15 to 25% of long COVID cases, up to 2 years after infection due to vascular and endothelial damage. And the demographic differences. Non-Hispanic Black and Hispanic men show higher rates than non-Hispanic white men in U.S. data, reflecting socioeconomic and healthcare access disparities. The bottom line, ED is everywhere. It is underreported, and millions of men suffer in silence when they do not have to. Let's get into the causes, and there are more than most people realize. The number one cause of ED is vascular, specifically impaired blood flow to the penis. This is called vasculogenic ED, and it accounts for the majority of organic cases. The culprits? Atherosclerosis, hardening and narrowing of the arteries; endothelial dysfunction, damage to the lining of blood vessels that impairs their ability to relax and dilate; hypertension, diabetes, and smoking. Here is the critical insight that doctors use all the time. The arteries supplying the penis are smaller than the coronary arteries feeding your heart. This means they get damaged by atherosclerosis earlier. Erectile dysfunction can precede a heart attack by 3 to 5 years. If you have ED, your doctor should be checking your cardiovascular health. Seriously. Diabetes is a massive contributor. Chronic high blood sugar accelerates atherosclerosis, causes oxidative stress, and damages the endothelium. The damage is worse with smoking because nicotine constricts blood vessels and worsens progressively over years of poor glycemic control. Speaking of nicotine, this includes vaping. A large population-based study found that daily e-cigarette users aged 20 to 65 were more than twice as likely to report ED compared to never users, even among otherwise healthy individuals with no prior cardiovascular disease. The risk is dose-dependent. The good news? Cessation works. Within 24 to 36 hours of quitting, measurable improvements in penile blood flow have been documented. By 3 to 6 months, approximately 50% of quitters report meaningful ED improvement. Neurological causes include peripheral and autonomic neuropathy, often from diabetes, damaging the nerves that signal an erection. Spinal cord injuries disrupt central neural pathways. Multiple sclerosis impairs signal transmission from brain to penis. Hormonal causes include hypogonadism, low testosterone below 300 nanograms per deciliter, which occurs in up to 35% of men with ED. Hypothyroidism also plays a role, slowing metabolism and affecting vascular health. Correcting hypothyroidism with levothyroxine often improves erectile function. Structural causes include Peyronie's disease, affecting 3 to 9% of adult men, where fibrous plaques curve and deform the penis. Post-prostatectomy damage affects cavernous nerves, causing ED in approximately 85% of radical surgery patients. And medications? Yes, medications cause ED in about 25% of cases. Antihypertensives, antidepressants, antipsychotics, beta blockers. Always review your medication list with your doctor. Now for the causes that are invisible but equally powerful, the psychological and lifestyle roots of ED. Let's start with the mind. Depression increases ED risk by nearly 5-fold. And here is the cruel irony. ED itself triples the risk of developing depression. It is a vicious cycle. Anxiety disorders, especially performance anxiety, heighten sympathetic nervous system activity, flooding the body with adrenaline and cortisol, literally constricting the blood vessels needed for an erection in a feedback loop of fear and failure. A key clinical clue: if a man has normal erections during masturbation or upon waking, those morning erections, but struggles during partnered sex, the cause is almost certainly psychogenic. The parasympathetic nervous system, the one that creates erections, functions perfectly in low-pressure solo situations, but gets overridden by the sympathetic fight-or-flight response during partner sex. In younger men, psychological causes dominate. Stress from work, relationship conflicts, performance anxiety, fatigue, insecurity. These are the primary drivers in men under 40. The encouraging news: psychogenic ED in young men is often highly reversible. A 2024 study of young men with psychogenic ED treated with daily low-dose tadalafil showed spontaneous medication-free recovery in 43% after 3 months, 60% after 6 months, and 72% after 12 months, with an overall recovery rate of 85%. Lifestyle factors are massive. Excessive alcohol, more than 14 drinks per week, damages endothelial function and peripheral nerves. Smoking increases ED risk by up to 51%. Obesity, particularly a 42-inch waist versus 32 inches, raises ED risk by up to 50% through vascular and hormonal disruption. Sedentary behavior promotes endothelial dysfunction. Insufficient sleep, fewer than 6 hours, disrupts testosterone, elevates oxidative stress, and impairs erectile function. Cannabis use has been linked to increased ED risk in some studies. Benzodiazepines are associated with ED, decreased libido, and orgasm difficulties. Dehydration is overlooked but real. When dehydrated, the body releases angiotensin II, a hormone that constricts blood vessels and raises blood pressure, limiting the blood flow needed for erection. Stay hydrated. Nutritional deficiencies matter too. Magnesium, zinc, selenium, potassium all play roles in vascular health, nitric oxide signaling, and testosterone production. A 2022 study found increasing dietary magnesium, zinc, copper, and selenium within safe limits beneficial for reducing ED prevalence. Get a blood test before supplementing. Excess copper, for example, can actually increase ED risk. Let's go deep into the biology and understand why these disruptions cause erectile dysfunction. In a healthy erection, the process starts in the brain. Sexual stimulation activates the parasympathetic nervous system, specifically sacral spinal cord segments S2 through S4. This triggers the release of nitric oxide from nerve endings in the cavernous nerves. Nitric oxide diffuses into smooth muscle cells in the corpora cavernosa, the two spongy chambers that fill with blood, where it activates an enzyme called guanylate cyclase. This increases levels of cyclic guanosine monophosphate, or cGMP. Elevated cGMP reduces intracellular calcium, which relaxes the smooth muscle. Relaxed smooth muscle means arteries dilate, blood rushes in, up to 20 to 40 times normal flow. The sinusoidal spaces fill. Venous outflow gets compressed against the rigid tunica albuginea, and pressure rises to about 100 millimeters of mercury. Rigidity achieved. Now in ED, at any point in this cascade, the process can fail. The most common failure point is reduced nitric oxide bioavailability. Endothelial dysfunction, driven by atherosclerosis, diabetes, smoking, aging, oxidative stress, impairs the endothelial cells that produce nitric oxide. Reactive oxygen species, free radicals, actually scavenge and destroy nitric oxide before it can do its job. Without enough nitric oxide, not enough cGMP is produced. Without enough cGMP, phosphodiesterase type 5, PDE5, degrades what little cGMP exists and the smooth muscle stays contracted. No vasodilation, no erection. This is exactly why PDE5 inhibitors like Viagra work. They block the enzyme that destroys cGMP, allowing whatever cGMP is produced to accumulate and drive vasodilation. They do not create an erection out of nowhere. They amplify an existing signal. You still need sexual stimulation. Neurological disruption cuts the signal earlier in the chain. Damage to the pudendal nerve or central pathways means the message to release nitric oxide never arrives. Fibrotic changes, excessive collagen deposition driven by TGF-beta signaling and hypoxia, replace the elastic smooth muscle tissue with rigid scar tissue. The chambers cannot expand. Elastic fiber content in potent men is around 9%. In men with venogenic ED, venous leakage, it drops to 5%. In arteriogenic ED, to 4%. Aging further reduces elastic fiber density alongside increasing fibrosis, stiffer, less compliant tissue confirmed by shear wave elastography. Hormonal failure from low testosterone downregulates the enzyme ENOS, endothelial nitric oxide synthase, reducing nitric oxide production at the source. Understanding this biology is not just academic, it directly determines which treatment will work for you. If you or someone you know is experiencing ED, here is how doctors approach the diagnosis and what you should expect and ask for. It starts with a thorough medical history. Your doctor will assess onset. Was it sudden, suggesting psychogenic causes or an acute vascular event? Or gradual, pointing to chronic conditions like cardiovascular disease or diabetes? They will use validated questionnaires, the International Index of Erectile Function, or IIF, a 15-item self-report tool scoring erectile function, intercourse satisfaction, orgasmic function, sexual desire, and overall satisfaction. Scores under 10 indicate severe ED, under 16 is moderate, under 21, mild to moderate, under 25, mild. They will ask about morning erections. Their presence suggests preserved neurological and vascular function and points toward psychogenic causes. They will ask about erections during masturbation. They will review all medications, antihypertensives, antidepressants, antipsychotics. They will screen for comorbidities, hypertension, diabetes, hyperlipidemia, cardiovascular disease, neurological conditions, prostate issues. The physical examination covers genital anatomy, checking for Peyronie's plaques, testicular size for hypogonadism, signs of infection. Vascular assessment includes palpation of femoral and pedal pulses for peripheral artery disease. Neurological testing checks perineal sensation, anal sphincter tone, and the bulbocavernosus reflex. Laboratory tests include morning serum total testosterone. Levels below 300 nanograms per deciliter indicate potential deficiency. Fasting blood glucose or HbA1c for diabetes screening. Lipid profile for cardiovascular risk. Thyroid function tests if hypothyroidism is suspected. The gold standard for evaluating vascular causes is penile Doppler ultrasonography, often performed after an intracavernosal injection of a vasodilator. Key parameters: peak systolic velocity below 25 to 30 centimeters per second suggests arterial insufficiency. End diastolic velocity above 3 to 5 centimeters per second indicates venous leakage. Nocturnal penile tumescence testing, measuring erectile events during sleep, helps differentiate psychogenic from organic ED. Adequate rigidity is defined as at least 60% at the penile tip for a minimum of 10 minutes across multiple nights. In select cases, MRI can investigate structural abnormalities. Intracavernosal injection testing evaluates erectile response directly. A rigid erection within 10 minutes and sustained for 30 minutes indicates intact vascular mechanisms. Remember, ED can be an early warning sign of cardiovascular disease. A thorough evaluation is not just about sexual health. It is about your heart, your metabolic health, and your longevity. Now for the part everyone wants to know: how do you treat it? Let's start with the foundation: lifestyle changes. Because for many men, especially those with mild to moderate ED, lifestyle modifications alone can restore erectile function without a single pill. The evidence is compelling. Comprehensive lifestyle changes, targeting weight, exercise, diet, smoking, and alcohol, have restored normal erectile function in a significant proportion of affected men in randomized controlled trials. Weight loss is powerful. A randomized trial of 110 obese men showed that a 10% or greater reduction in body weight led to 31% of participants regaining normal erectile function, compared to just 5.5% in the control group. Reducing waist circumference from 42 to 32 inches can cut ED risk by up to 50%. Target a BMI below 25, ideally 23 to 24. Safe weight loss: 5 to 1 kilogram per week. Exercise is a game changer. At least 150 minutes per week of moderate intensity aerobic activity, brisk walking, cycling, swimming, reduces erectile difficulties by up to 41%. A systematic review found that 160 minutes per week of supervised aerobic exercise for 6 months resulted in 14 to 86% relative improvements in erectile function. Combine aerobic exercise with strength training for maximum benefit. Pelvic floor exercises, Kegel exercises, are often overlooked. Studies show success rates up to 40% achieving normal erectile function after 3 to 6 months of pelvic floor training. For venous leakage ED specifically, targeted pelvic floor training can be an alternative to surgery. Contract the pelvic floor as if stopping urine flow, 10 to 20 reps per set, 3 to 5 sets daily. Diet matters enormously. The Mediterranean diet, rich in fruits, vegetables, nuts, fish, and olive oil, is associated with a 22% lower risk of ED in men under 60. Nitrate-rich foods like beets, spinach, and arugula convert to nitric oxide in the body. Watermelon contains L-citrulline, which boosts nitric oxide. Flavonoid-rich berries, citrus, and dark chocolate, minimum 70% cocoa, support vascular health. Zinc-rich foods like oysters, beef, and pumpkin seeds support testosterone. Smoking cessation is critical and fast-acting. Within 24 to 36 hours of quitting, measurable improvements in penile hemodynamics occur. By 3 to 6 months, approximately 50% of quitters report meaningful improvement. Quit smoking, quit vaping. All forms of nicotine impair penile blood flow. Sleep 7 to 9 hours nightly in a dark, quiet environment. Limit alcohol to under 14 standard drinks per week, or eliminate it entirely if heavy use is present. Manage stress with mindfulness-based practices. A review of over 3,700 men found improvements in erectile function and sexual satisfaction following mindfulness interventions. For psychological ED, cognitive behavioral therapy, CBT, significantly enhances erectile function in up to 70% of participants after 3 to 6 months. Couple-based therapy improves outcomes and communication. Supplements with some evidence include L-citrulline at 1.5 grams per day, which improved erection hardness scores with 50% achieving normal function after 1 month in one study. L-arginine at 1,500 to 5,000 milligrams per day shows modest benefits. Korean red ginseng at 1 to 3 grams per day has some supporting meta-analyses. Icarian from horny goatweed and Sistanchi extracts show preclinical promise. But supplements are not rigorously regulated, carry risks of side effects and drug interactions, and should always be discussed with your doctor first. When lifestyle changes are not sufficient, or when the cause is more severe, there is a powerful arsenal of medical treatments available. The first-line pharmacological treatment recommended worldwide is the class of drugs called phosphodiesterase type 5 inhibitors, or PDE5 inhibitors. These work by blocking the enzyme that destroys cGMP in penile smooth muscle cells, prolonging vasodilation and enabling erection in response to sexual stimulation. They do not create erections on their own. Sexual arousal is still required. The 4 approved PDE5 inhibitors are sildenafil, brand name Viagra, taken at 25 to 100 milligrams about 1 hour before activity, effective in about 70% of mild to moderate ED cases. Tadalafil, Cialis at 5 to 20 milligrams on demand, or 2.5 to 5 milligrams daily, providing up to 36 hours of efficacy, making it the most convenient option for spontaneity. Vardenafil, Levitra, similar in onset and duration to sildenafil. And Avanafil, Stendra, the fastest-acting, working in as little as 15 minutes. Overall, meta-analyses show approximately 57% successful intercourse attempts with PDE5 inhibitors versus 21% with placebo, with about 83% of users achieving at least one successful encounter. Apparent non-response is often correctable. Taking the medication after a fatty meal, insufficient sexual stimulation, incorrect dosing, or too few attempts are common reasons. Important caution: PDE5 inhibitors are contraindicated with nitrate medications due to the risk of severe and potentially fatal hypotension. Never combine them without strict medical supervision. Common side effects include headache, flushing, and nasal congestion. For patients who do not respond to oral PDE5 inhibitors, or those who prefer non-oral routes, intracavernosal injections of alprostadil can induce an erection in 5 to 15 minutes, lasting up to an hour. Intraurethral alprostadil suppositories achieve adequate erections in approximately 30 to 40% of users. An emerging treatment, intracavernosal injections of botulinum toxin, Botox, in refractory or vasculogenic ED. Clinical studies show response rates of 40 to 77.5%, with effects peaking at 3 months and lasting up to 6 months. This is not yet a standard treatment, but shows significant promise. For men with confirmed hypogonadism, low testosterone, hormone replacement therapy via transdermal gels, patches, or intramuscular injections improves libido and erectile quality in 40 to 60% of cases. Combining testosterone replacement with PDE5 inhibitors yields synergistic improvements. Low-intensity extracorporeal shockwave therapy, LIESWT, delivers acoustic waves to penile tissue, promoting new blood vessel growth and improving endothelial function. Meta-analyses from 2020 to 2025 report approximately 50% improvement in IIF scores. Benefits can last up to 2 years. Most effective for mild to moderate vasculogenic ED. Important note: at-home shockwave devices like the Phoenix lack the clinical power of professional equipment. Most experts say they do not work effectively. Vacuum erection devices, penis pumps, draw blood into the penis using negative pressure with a constriction ring maintaining the erection. Success rates of 70 to 90%. Long-term use may help some men regain spontaneous erections, but avoid prolonged use. Overuse can damage elastic tissue and actually worsen erections over time. For severe or refractory ED, penile implants represent the definitive surgical solution. Inflatable penile prostheses allow on-demand rigidity with a natural, flaccid state. Patient and partner satisfaction rates are around 90%. Complication rates are 2 to 11%, including infection in 1 to 3%, reduced by antibiotic-coated implants. Stem cell therapy, injecting mesenchymal stem cells intracavernosally to regenerate endothelial cells and smooth muscle, is in Phase 2 clinical trials as of 2025 with promising preliminary data. Gene therapy targeting nitric oxide pathways shows preclinical promise. These are not yet standard treatments, but represent the frontier of regenerative medicine for ED. Erectile dysfunction is not new. The Ebers Papyrus, dating to 1550 BCE, documents ancient Egyptian treatments for impotence, including herbal suppositories and ointments. Greek and Roman physicians prescribed aphrodisiac herbs like satyrion root and pine nuts. In the 11th century, Avicenna's Canon of Medicine recommended dietary adjustments and herbal concoctions. The modern era of ED treatment began in 1982 when French urologist Ronald Virague accidentally discovered that intracavernosal papaverin injections during surgery produced an erection, launching the era of injection therapies. Then in 1998, the FDA approved sildenafil, Viagra, the first oral PDE5 inhibitor. This was a revolution, not just pharmacologically, but culturally. For the first time, men could walk into a doctor's office, describe ED, and leave with a pill. Discussions that were once whispered became mainstream. But stigma persists. Globally, up to 75% of affected men remain untreated because they view ED as a personal failure, a threat to masculinity, an embarrassment. This is a tragedy, because ED is a medical condition, not a character flaw. The very language shifted to reflect this. In 1992, the National Institutes of Health replaced the word impotence, which connotes a broader inadequacy, with erectile dysfunction, a specific physiological, treatable medical condition. For partners, surveys show that nearly 60% of women report that their partner's ED does not affect their relationship. Among those who sought help together, approximately 75% felt more positive about the relationship, expressing empathy, optimism, and improved communication. Honesty between partners is not weakness. It is often the most powerful first step toward recovery. For younger men, ED in your 20s and 30s is more common than you think, primarily psychogenic and highly reversible with appropriate intervention. Do not ignore it. Do not be embarrassed. See a urologist or andrologist. Rule out organic causes. Get treated. The 2020s have seen extraordinary advances: stem cell therapies, gene therapy, LIESWT, botulinum toxin injections, and regenerative medicine approaches that may one day offer curative, not just symptomatic, treatment. The future of ED management is brighter than ever. Let's lock in your knowledge with today's key takeaways. Number 1. ED is defined as difficulty achieving or maintaining erections on at least 75% of occasions, persisting for at least 6 months, causing significant distress. Number 2. Over 52% of men aged 40 to 70 are affected. 322 million men worldwide will be affected by 2025. You are not alone. Number 3. The most common cause is vascular. Impaired blood flow from atherosclerosis, endothelial dysfunction, diabetes, hypertension, and smoking. ED can be an early warning sign of heart disease. Number 4. Psychological causes, especially performance anxiety and depression, are the primary cause in younger men and are highly treatable. Number 5. Lifestyle changes. Exercise, weight loss, quitting smoking, Mediterranean diet, adequate sleep can restore normal erectile function in a significant proportion of men without medication. Number 6. First-line medications. PDE5 inhibitors like sildenafil and tadalafil are safe, effective, and work in 70 to 80% of men. They require sexual stimulation and are contraindicated with nitrates. Number 7. Penile implants have 90% satisfaction rates for severe refractory ED. Number 8. Stem cell and gene therapies are on the horizon as potentially curative treatments. Now, let's test your retention. Here are your Q&A questions. Pause the video and think through your answers. Question 1. What percentage of men aged 40 to 70 experience some degree of erectile dysfunction according to the Massachusetts Male Aging Study? Question 2. Which enzyme do PDE5 inhibitors block, and why does blocking it help produce an erection? Question 3. Name 3 lifestyle changes with clinical evidence for improving erectile function. Question 4. What is the key clinical clue that suggests a man's ED is primarily psychogenic rather than organic? Question 5. Which dietary pattern is associated with a 22% lower risk of ED in men under 60? How did you do? Drop your answers in the comments. I read every single one. Now here is your challenge for this week. If any of today's information resonated with you or someone you love, share this video. One share could change a man's life, his relationship, or even save him from an undetected heart condition. If you found value here, subscribe to DrSchammaexplains, where we take the most important, most misunderstood medical topics and break them down with clarity, evidence, and zero judgment. Your question for today: what surprised you most in this video? And what do you most want to understand better? Comment below and let's keep the conversation going. Next up, we're covering the cardiovascular connection, why your heart and your bedroom performance are more linked than you ever imagined. You do not want to miss it. See you in the next one.